FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.
Esse é o FRêMITO Podcast Vascular, direto do Congresso Brasileiro de Angiologia e Cirurgia Vascular, e a gente está tendo a máxima honra de receber aqui o professor Joseph Coseli, que veio ao Congresso e vai trocar uma ideia com a gente sobre a história e os seus números do tratamento do aneurisma toracoabdominal. So, Dr. Coseli, it's a very pleasure and an honor for us to receive you here.
It's an honor to be here. It's truly a pleasure.
And for us young vascular surgeons that read so many papers and books chapters of your practice, we really want to know about the beginning of the history of the aorta treatment.
Well, there's more papers coming.
So,
it's not over yet, right?
Stay tuned. Very interesting. First of all, I apologize. I don't really speak Portuguese, despite many trips and times, wonderful times here in your great country of Brazil. I was born and raised in Texas, and it's part of the country where we're still trying to master English. So Portuguese would be somewhat difficult. I trained at a time where vascular surgery was really in its infancy. It really got started in the late 50s and 60s. That's a long time ago for you guys. Even I was very young at the time, and one of the epicenters of that had to be Dr. Michael DeBakey, who attracted a great many vascular problems, and of course was the instigator of the Dacron graft to replace the aorta with a synthetic material. Prior to that, they'd been using homografts, and homografts are really great for a short period of time. But below the left subclavian artery, there's problems. It's not immune to infection, and it does calcify and deteriorate over time. Despite, having been used as fresh or fresh frozen and treated, et cetera, it just had some drawbacks. So they really needed a synthetic material that they could take off the shelf and use on a regular basis. And Voorhees in New York was probably the one that was first attributed with doing that. He used Vignon N. He was actually, for the young doctors out there, he was actually a resident when that happened. They were using that in the dog lab, and they had an emergency case, and his mentor was full-time faculty, and he went down and got the Vignon N, brought it up. They put it in an infrarenal aneurysm, and became kind of known as the first ones to do that. But it became really replicable and widely usable when Dacron came along, and we could replace virtually any part of the aorta. Back in those days, Dr. Cooley and Dr. DeBakey were working together, and Dr. Cooley was probably more of a cardiac surgeon, although he did a lot of vascular surgery, and then Dr. DeBakey was more of a sort of vascular surgeon, although both of them overlapped with all that. There's a quote by a friend of ours that's involved in heart transplantation and devices named Bud Frazier. And he liked to say that Dr. Cooley took the proximal portion of the aorta and Dr. DeBakey took the renal on down, and nobody wanted to fool with that really dangerous area in between called the thoracoabdominal aorta. And so Dr. Stanley Crawford picked that up and really revised it. And in the very early days, they would do a bypass from the upper end of the aorta to the lower end, and then take the entire aneurysm out, all of it, and then replace it with a homograft, or later with Dacron, and then take the bypass down. The bypass was usually Invalon. One of Dr. Crawford's contributions was to put the graft inside the aneurysm and then wrap it, rather than extirpating the whole aneurysm, which you could imagine didn't help with the bleeding situation. And so it was more of an endoaneurysmal kind of reconstruction with the Dacron on the inside. Dr. DeBakey, very early on, actually, his first report was 4 cases of thoracoabdominal aneurysms. I think the mortality was 2 of them survived. And even in that early paper, they recognized the problem with paraplegia. And so one of Dr. Crawford's goals through his career was to investigate various therapies and ways to try to reduce the incidence of spinal cord ischemic injury. And we've continued with that. Dr. Crawford practiced until late January 1991. I was working with him at the time. I'd trained under DeBakey and stayed on and built on what he had already done and continued to attack the aorta from the aortic valve to the groins.
Wow. This is very interesting for us. We're very happy to be here listening. You talking about your old friends, Dr. Crawford, DeBakey, Culling. And we know we have challenges today, but we can imagine what might have been the challenges you have back then. So this is very, very interesting. Thank you for sharing with us. And what about the evolution? This is the first steps, like in the early times of the aortic surgery. What were the next steps of this evolution?
Well, Dacron today still remains for open surgery certainly the material of choice. So when you look at the instance of paraplegia, Dr. Crawford took it upon himself to run some trials to see if various things which were becoming popular at the time were going to be useful. I'll step back just a little bit, but the first thoracoabdominal that's really sort of considered a success was carried out in California by a fellow by the name of Etheridge, and he used a homograft and a bypass around the whole area as I described before. But once they started replacing a lot of the thoracoabdominal aorta, they recognized again that the risk of paraplegia was bad. To have a kidney go down, you can still function. If you lose both kidneys, you can still get dialysis. It's a bad situation, but it's usually not lethal. But paraplegia is a devastating situation in every aspect of the issue, because it's obviously critically devastating to the patient. It's life-altering, life-changing, and financially changing for the family and the people around them. And then from a societal standpoint, it's one of the problems which are extremely expensive to deal and to manage with. And so he set about trying to change that as best he could. And I'm not here to say that he did a perfect job, but he took on the situation as well as he could at the time. I'm going to talk about this a little later, and a little bit of this in the talk coming up. But one of the things he did is he got interested in cerebral spinal fluid drainage in order to reduce the pressure on the spinal cord, et cetera. And so we ran a clinical trial. It wasn't a large number, but it was basically some high-risk aneurysms with thoracoabdominal with and without CSF drainage. And the situation was that the conclusion of that trial was that there was no difference, that it didn't impact what we were trying to see and what we were seeing with regards to spinal cord issues.
What year was that, more or less? Just you.
Mid-'80s.
Okay.
Mid-'80s. I have some slides on a recent presentation coming up. But the thing that we ran into on that trial was that our institutional review board, our IRB, which oversaw what you could do for human trials, limited us as to how we can conduct that trial. Mm-hmm. And the limitations were placed on us by people on the IRB that really weren't all that familiar with what we were doing, quite frankly, pediatricians and I don't know. And so the way that trial had to be conducted was focusing on the amount of volume which we could extract from the spinal cord space of CSF fluid, and really didn't allow us to focus on the pressure. And the amount that they allowed us to drain was small compared to what we would think of today. Okay. And then the second thing was we had to remove the CSF catheter at the end of the procedure, so that restricted us from being able to draw fluid after the operation. Mm-hmm. So as a consequence, as you might imagine, the paraplegia rate probably wasn't any different. which sort of soured Dr. Crawford on using CSF drainage. There was some interest primarily in New York by a vascular surgeon by the name of Joe Cunningham, which was at the time interested in somatosensory evoked potential monitoring and using left heart bypass. Left heart bypass goes back to the early days of Cooley Crawford and lots of other people. And the combination of those two and using SCP monitoring to try to identify and maybe change something intraoperatively and technically. And so Dr. Crawford set up a clinical trial to do that. And it's not one that I really refer to very often, but actually he brought Joe Cunningham down to Houston to New York with the idea of having Joe see exactly what we're doing. The concern would be Joe's doing some certain things in New York. We're trying to run a clinical trial doing the same thing. But at the end of the trial, if it didn't end up being the way Joe Cunningham thought it might or should come out, Joe theoretically might say, well, you weren't doing it the way I do it. So we brought him down to Houston and showed him what we were doing, and Joe Cunningham put his stamp of approval on it so that to eliminate issues later like that. And it didn't help us either. With SCP monitoring, we had so many false negatives and false positives that with regards to altering anything we did, it didn't have an impact. The results of paraplegia at that time weren't that bad anyway. One of the problems that you run into, and we had a graft in a paper that we published about 86, 88. But one of the things you run into statistically is if you have an incidence of a problem and you want to alter the problem with an intervening, so you got a control group and an intervention group. If the control group has a very high incidence of the problem, 10, 20, 30%, the number of patients it takes to have a statistically significant difference, altering it to make it better, is a relatively very small number compared to taking an incidence of 2% or 3% and try to statistically impact it. So you run into some of these problems, you run into some issues with that. The other things that we did is I became interested in reattaching intercostal arteries more so than Dr. Crawford was. And so I've never, it's very difficult to carry out a prospective randomized trial on that because the anatomies and everything are very, very variable. But we have published, looking back at just the extent to aneurysms when we reattach a lot of intercostal arteries, it lowers the incidence of paraplegia. It's retrospective, but it's over 1,000 patients. So we still go by that. I don't think in most of the guidelines there's a number one indication for it. That's probably a 2A or a 2B, but we still strongly believe it when we can. We've been advisors to the European Papa Artist trial, which kind of builds up on Randy Greep's collateral circulation concepts, which have lots of different implications. With that trial, they go in preoperatively on endovascular cases as well as open cases and coil the intercostal and lumbar arteries in 1 or 2 sessions and then come back and then do the procedure. We're still waiting on the results of that trial, but it included a lot of different patients, everything from just descendings to thoracoextent 2s to endovascular cases. And so, that's still out there. The reason I bring that up is because conditioning of the circulation of the spinal cord is a concept that flies against the earlier ideas of the circulation of the spinal cord generally being fed by the circle of Willis. And it's the anterior cord that we're concerned with, and by an artery of Adam Kiewicz coming off of a lower intercostal artery that then supplied primarily the cardiac quina and the lower card. And frequently that anterior spinal artery between those two would be very, very small, and sometimes even almost non-existent, so that there was sort of a dead space in between. And the idea would be to prepare the cord and circulation in such a way as to realign itself and improve that native condition to something which would be more tolerable of the ischemia and everything of open surgery or endovascular surgery, which comes into staging procedures, which there's a paper early on by Randy Greep and his group at Mount Sinai about doing thoracoabdominals that they had done not so much on purpose, but they had ended up being staged. They did the lower part first, then the upper part, or the upper part first, then the lower part, and had some reasonably good results with staging them. The problem with that operation is it's putting people through two open operations is a lot. One open operation is sometimes more than enough, and that leads into the concept of downgrading the open portion, which we do not infrequently, given the right anatomy. In other words, we'll put a TVAR or a branch TVAR in the proximal aorta and let that be it as it may, and then come back and do the rest of it open, including the iliacs if necessary. And part of the idea of that is to stage the issue to the spinal cord, but also has the benefit of making a lower intercostal incision for the open procedure, which from a pulmonary standpoint is better tolerated, the lower you can go. And finally, we all got involved in EVAR and TVAR back in the early 90s and continue to do all of that. But in the last decade or more, interest in replacing the thoracoabdominal aorta with endovascular procedures is really becoming a dominant way to manage these things. And it's certainly true that it can be done on patients who would very unlikely tolerate an open operation. There's still durability issues. I think our industry partners still need to help us out there with a lot of things. I mean, you can imagine, we didn't have some of these devices and catheters and things we have now 10 years ago, but we need to keep moving forward in that direction, both on durability, on technique, and some of the software on guiding where to place things, et cetera, has become increasingly valuable. But down that line, and I'll make the point in my talks here coming up, that we still need to, in many cases, keep our open skills available to us, because there's going to be some patients who are, despite endovascular therapies or potential for endovascular therapies, are going to be best served by an open operation. Some examples: a very young patient with a severe connective tissue disorder, a heritable aortic condition, severe Marfan, Louis-Dietz, VEDS, et cetera. That we land our endovascular devices still, and this is something that could be changed eventually. You sort of we think things as gospel, but there's always somebody, anyway, comes up with something. It's still primarily radial force against not an old man's sclerotic aorta that's got a little calcium in it, but it's up against a young patient whose aorta is just conditioned to keep getting bigger and bigger and bigger. So some of these young patients are going to need it. The other areas where open surgery is going to be necessary is infection. When the endovascular grafts become infected, explantation is really only the hope for truly treating that in most cases, and so it requires an open operation. And then there's fistulization into the esophagus and into the bronchus. You can tide those over frequently for a while to prevent the bleeding into the secondary organ. But in most of those cases, an open operation is going to be necessary if you really want to completely remediate the pathology from the patient.
So, Doctor,
that's a lot of stuff. I hope.
Yeah, we know, but we really want to know more. So, you, doctor, and your colleagues changed the history of aorta treatment. So, how do you see the future, the next 30, 40 years in aorta treatment?
Well, the next 30 or 40 years, I think open is probably going to be gone. Okay.
Even on those cases you said?
I've listed out some problems that have been identified, and what needs to happen is like we had problems of clotting when we clamped an artery. So we give heparin. So there's ways of solving problems as they're identified going down the line. We know that I didn't talk much about our how we manage the kidney these days, but in open cases. But so go back. There's infection. Somebody somewhere sometime is going to come up with endovascular devices and material which are infection resistant. It sounds almost impossible today, but when I was growing up, if you said stomach ulcers were caused by bacteria, they would have kicked you out of medical school. So things change, okay? And you can't be so dogmatic that you just can't believe it can't be done. And with regards to the other things which are common, and that is, say, fistulization, you know, there should be ways of preventing that, either on the device management side or some sort of minimally invasive way of managing.
Identifying earlier, maybe.
With thoracoscopic techniques or something to do something with the anatomy in a simple way to separate the organs or in such a way as to prevent that. It should be doable, but somebody out there could do it. With regards to the very, very young people with severe connective tissue disorders, we've come along. We're in our lab as in others. We're certainly looking at single cell RNAs, looking at the mechanisms of the cascade of events intracellularly, which in a patient with a connective tissue disorders, why does that deteriorate the way it does? It doesn't have to do that. Yours doesn't. I don't think. And so I truly believe that with eventually we're going to have pharmacological ways of taking patients identified basically in utero of having a connective tissue disorder
in such a way that they don't need surgery at all.
Pharmacologically manage it so the aortas never go bad. And I think that's the goal, but it's a way off. But 40 years is a long time.
So we need to find another job.
Dr. Coseli, let me ask you about your vision.
Take a quick story. I have a videotape of Dr. DeBakey, and he did it as for a local TV station in Houston back in the 1960s. And the guy asked him a question similar about this, and he put his hand on the operating table, and he said, "With enough research in the right direction, we won't need this operating table anymore." That was the 1960s.
Wow.
Maybe right, but just a little early. Sort of a Cassandra.
Dr. Coseli, I want to know about your vision of how are you training young surgeons in open surgery in Baylor, and what is your vision about that?
Good question. In the interim, we definitely need people who can do open surgery to address the issues that we have just been discussing. We have a robust program where we are. We do a lot of endovascular, but we also have a very strong balance of open surgery as well. We offer both. And I'll tell you the way we have a vascular residency program. We also have a thoracic residency program, and both of those get exposed to all of that. The way we take almost every aortic, for a long time now, every aortic case that we come to evaluate, our first approach is can this be managed with an endovascular technique? And then the second question is either yes or no. If no, it goes to open surgery. If the answer is yes, then the next question is should it be done with an endovascular technique as opposed to open? And that goes back to the extent to Marfan patient that's got a dissection and very, very friable aorta, et cetera, et cetera. We can put a graft in there, but we think in terms of many, many, many years for a patient like that. It may not be the best first solution, but probably a very, very good second solution later.
Because it's a worldwide problem now. We worry about it. Our residence program have like open surgery and endo, but the tendency, we think it's more endo, and we worry about it too.
Yeah, it's very interesting. When we first started doing endo, I was the PI for the first trial in Houston for the Gore EVAR graft, and also was a PI of the trial for their thoracic graft. But we started getting residents who wanted to do vascular training. Their big question was, how much endovascular am I going to get to do? You guys are operating on all these people. And within a very few years, it became the other way around. They want to know how much open they're going to get. They go to a lot of programs, and they're not see any open. Until there's a third issue with open, fourth issue with open surgery that I didn't really address, and that is there's the emergency cases that need to be managed immediately in hospitals in our country and your country that are very remote. And to have the devices, the technical capability, the knowledge, and the comfort level to manage these things we're growing in that direction. But I don't think we're not quite there all the time yet. So an example of how that goes, if you do a vascular residency, I'm not sure what the exact numbers are now, but you do very few open ruptured abdominal aortic aneurysms in your training. Probably not enough to be signed off as somebody who should be going out and doing those things. But that's pretty much always been the case. Even when we were training, we did well over 100 open abdominal aortic aneurysms between aneurysms and aortobifims, et cetera. Easily we did over 100, maybe a lot more. But the way at that time, the fellow out in the countryside that had a patient who was hypotensive and needed to be on the operating with the aortic clamp now, knew how to do that was because he had had a large experience in elective open abdominal aortic aneurysms. And so he took the small knowledge of rupture and his extensive knowledge of the routine elective case and used that in the emergency situation to adapt his other knowledge and made it something that would be quite satisfactory to the patient. So we're still not quite there yet that out in every possible situation where somebody shows up with a leaking AAA that somebody's there who can treat that endoscopically, particularly if there's issues with access or the neck being funnel shaped, tortuous. I mean, on and on. You guys know that as well as I do.
So it's amazing to have you here, doctor, and I really want to you to leave a take-home message for all our vascular surgeons here in Brazil that you see this interview after.
Let me put it this way. Hopefully there's a lot of young vascular surgeons and maybe people interested in doing vascular surgery. I talk about history a lot because I like it, but we have a lot to learn from history. So let's look back historically as to how things happened. And one of the things that happened was that a lot of the doctors that developed the specialty as we know it, open, endovascular, et cetera, they didn't start out doing those cases. They trained learning basic surgery so that they understood the problems, the anatomy, how to take care of patients, et cetera. And then they learned in their practice by being open-minded, not dogmatic, and adapting to new things because there's a new idea here and a new idea there. And they would grab onto those new ideas, see if they worked. If they didn't work, great, et cetera. So they built their practice in such a way as to increase their knowledge and evolve their practice towards the state of the art, whatever that may be at the time. And a lot of the guys that I studied with and learned from, not only did they do that, they actually pushed the envelope and helped move the specialty forward with further advancements. And so if you're young, I would say try to get a great foundation in surgery, keep learning, and have a practice that evolves over time. Because techniques, devices, and way we think about things, in the lifetime of their career is probably going to be, almost certainly going to be a little different than the way they start out. But they need to be adaptable to it, and they'll be ahead of the game doing that. Example, Dr. Cooley and Dr. DeBakey both did their training before cardiopulmonary bypass for heart surgery was invented. But they ended up doing an awful lot of it when it came around. They adapted it and improved it. Same way with the vascular techniques and things. But both of them were exited prior really to the endovascular era. But I'm sure that that type of individual, had they expanded their time frame into the endovascular era, they would have adopted that as well.
Perfect.
Thank you very much, Dr. Coseli, to have you here.
It's a pleasure.
Não deixe de continuar acompanhando os episódios do FRêMITO Podcast Vascular, direto do Congresso Brasileiro de Angiologia e Cirurgia Vascular.
FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.